I'm Joe Broderick from the University of Cincinnati. It's my pleasure to introduce Jason Davies from the University of Buffalo, who's going to be the presenter of the EMBOLISE trial and is going to tell us about it. Jason.
Very good. So I'm very pleased to be able to speak with you today about the results of this trial. The EMBOLISE trial came about because the incidence of subdural hematomas is increasing. And the vexing problem is, although we can drain them very easily surgically, about 20% of them come back. No matter how good a job we do as surgeons, 20% come back. And part of that problem is that they tend to develop membranes over time. Those membranes are highly vascularized, and it sets in motion this vicious cycle where you get exudates and repeat microhemorrhages, and these take on a life of their own. And so they can be very difficult to control. And so over the past few years, a number of different institutions have been playing around with, well, what if we cut the blood supply, embolize the middle meningeal artery, and see if we can help to reduce that rate of recurrence. And so EMBOLISE is one of now multiple randomized controlled trials, 3 of which are being presented here at ISC this week, which hope to answer that. So the EMBOLISE trial is actually 2 trials in one. We have the population that fundamentally needs surgery, bigger hematomas, more severe deficits, and the folks who need surgery are then randomized into either getting the embolization or not. And in this case, we're using Onyx. The trial is funded by Medtronic, so we're using Onyx exclusively for the embolization procedure. But then there's another arm of the trial, which is the observation arm, where the patients have smaller hematomas, less severe deficits, and those are being randomized into either observation alone or with embolization. We're not presenting on that second cohort. This is just the surgical cohort that we're presenting on.
Okay. Well, it is a very important clinical problem. Before I was telling you, one of my friends had the very same issue that you shared. You had another person that
absolutely.
So it's a very common problem. When the surgeons make the decision to go and do the embolization, that's and it's randomized. Here randomized, one gets embolized for surgery, one gets just the surgery. How do they make that call? And the reason why it has to do with in trials, we like when things are blinded. This obviously can't be blinded, but you're having people make decisions based upon their sort of gut of what's needed, and then they get randomized. But then they also are following them up afterwards to assess, do they need another surgery, and how do they make those decisions?
Yeah. So let me divide that into 2 portions. Number one, the initial question of do they need surgery in the first place? And then the second question is, well, what about if things come back? Do they need a second surgery? So in the first place, it is usually at the surgeon's discretion. Now, in the context of this trial, we wanted to try to make things more standard. So there are bounds around the size of the hematoma, the amount of midline shift, the types of deficits that the patients have, the amount of blood that can be subacute or chronic versus acute. So we had some inclusion-exclusion around that to try to get a more homogeneous cohort here. But you're absolutely right that our primary outcome is around reoperation, and fundamentally, that's a surgeon decision. And so we debated long and hard about this because there are other ways of potentially looking at this, be it radiographic recurrence or other things. But we decided that the thing that was most important was, do they end up needing to go to the operating room? So we tried to give a lot of training and guidance around that. And it was, hematoma progression or recurrence with new or worsening symptoms that were associated with it. And we had a fairly rigorous process in place where the surgeons had to document at each of the follow-up time points, whether they be scheduled or unscheduled, what they're seeing, what their decision is, and why they made it.
And as you mentioned, you are collecting data about how patients do long-term. You are longer term. You're all collecting data about the actual growth of the hemorrhage or lack of growth of the hemorrhage. So you're going to have those things eventually, not tomorrow to be presented.
That's right.
But you'll have that information that'll give context to the primary endpoint in this trial.
Absolutely. We have a number of planned secondary analyses, including imaging, how that relates to the embolization that was done, the health economic outcomes, all sorts of things that we have planned for another discussion.
Absolutely. And the other thing, one of the things we talked about beforehand is the fact that 40% of people had already had a surgery,
That's right.
and they're coming, they're returning, and the others are brand new, kind of virgin kind of cases.
Yeah, let me clarify that. We didn't want to have a lot of heterogeneity in terms of having surgery 6 weeks ago and then coming in, getting randomized and getting it plus or minus, because we were worried that those patients may have already shown their cards, right? And so when we talk about the 40% that had had surgery prior to the embolization, that was within the index hospitalization. And sort of to account for the weekend effect where you may or may not have clinical studies folks at all of the sites. We say, okay, well, if they come in, they have a subdural that needs to get evacuated on Friday, you give them 72 hours to be screened, randomized, so that Monday morning you could do a procedure or get that done. So all of those who had it done prior, who had surgery prior to their embolization, were within 72 hours of it. Right. So hopefully we're not really, they haven't already shown their cards.
Right. Yeah. So the chronic membrane patients are the ones that you worry a little bit more about because
Absolutely.
Yeah. So
Absolutely.
And you want to stop it. You want to stop the pathology early rather than waiting for it to develop where it becomes a real issue long term.
Right.
So yeah.
Right. And I think there are a number of institutional studies that definitely have looked at those. My co-PI, Jared Notman, has published a lot out of Cornell. He was one of the really big first earlier authors on this, looking at these different cohorts. What about the patients who recur? What about the patients who have X, Y, and Z? And so people are really trying to look at that population as well, but that's not the focus of this.
Yeah. Well, very exciting.
Yeah.
Very exciting. We're going to have 3 trials and a 4th one getting close.
Very close, and some other international trials as well.
So when we get all that information together, it sounds like we're going to have a much better guidepost to say what we should be doing and the role of embolization in these different cohorts.
Absolutely.
And that's very exciting. So we can help
Absolutely.
improve outcomes.
Absolutely.
Thanks.
Absolutely. All right.